Finals SAQ44, Chronic Kidney Disease. You are asked to anesthetize a patient with chronic kidney disease. A. List organ system effects that must be considered. This has been answered in Finals SAQ31, Renal Transplantation, CKD and AKI. B. Outline pharmacological factors that must be considered. Pharmacokinetics. Drug absorption. For drugs administered via the oral route, high urea levels leads to delayed gastric emptying and risk of dose stacking. For example, oral metoprolol. Uremia reduces enzymatic metabolism, such as CYP3A4, and also inhibits P-glycoprotein efflux pump. This increases drug bioavailability. For drugs administered via inhaled route, there may be increased uptake of volatile anesthetic if there is increased minute ventilation due to metabolic acidosis caused by CKD. Reduced drug uptake occurs if there is increased diffusion distance caused by pulmonary edema. For drugs administered via subcute, IM or topical route, increased total body water leads to edema, increased diffusion distance and reduced rate of onset. Cardiorenal syndrome reduces blood flow to tissues. This reduces rate of onset and risk of dose stacking, such as for subcute morphine, IM adrenaline and fentanyl patches. Drug distribution. Increased ECF volume leads to increased volume of distribution of water-soluble drugs. This leads to increased loading dose needed to achieve target plasma concentration. Metabolic acidosis causes increased unionized percentage of acidic drugs such as thiopental, leading to increased toxicity. Acidosis reduces unionized percentage of basic drugs such as morphine, reducing its effects. Plasma protein concentration. Reduced plasma albumin levels leads to increased free acidic drug proportion such as diazepam, leading to increased toxicity. Increased free unbound drug fraction may increase clearance and distribution. Reduced doses of drugs highly bound to albumin such as benzodiazepines, barbiturates and propofol. Reduce local anesthetic dose by 25%. In CKD, there are increased levels of alpha-acid-glycoprotein. This leads to reduced free basic drugs such as morphine, reducing its effects. Drug metabolism. Hepatic. Urea inhibits CYP enzymes. Drugs such as morphine, petidine, and benzodiazepines are hepatically metabolized to water-soluble metabolites which are excreted by the kidneys. Active metabolites may accumulate with repeated dosing such as morphine 6-glucuronide and norpetidine, with subsequent respiratory depression and reduced consciousness. Remifentanil and fentanyl may be safely used as they have no active metabolites. Hepatorenal syndrome, if present, reduces hepatic drug clearance. Metabolism of sevoflurane and enflurane by CYP2E1 produces fluoride ions which are nephrotoxic. This is only a consideration if anesthesia is very prolonged. Reduced drug metabolism of certain drugs by the kidneys increases their duration of action, such as insulin. Drug excretion. Renal drug clearance is proportional to GFR. GFR, active secretion, and renal drug enzymatic metabolism are all reduced in CKD. This prolongs the effects of drugs such as penicillin, cephalosporin, neostigmine, salicylates, pancuronium, vecuronium, rocuronium, morphine, and petidine. Considerations for hemodialysis. Variable drug clearance occurs by hemodialysis. For small unbound particles, they are readily cleared, hence give after dialysis. For large bound drugs, they are unaffected, hence dosing schedule remains the same. Hemodialysis may lead to normalization of total body water. This reduces volume of distribution of water-soluble drugs. Adjust dosage accordingly. Overall implications of CKD. There is disturbance of all aspects of pharmacokinetics. This leads to unpredictable drug behavior. Titrate to effect. Consider reduction of dose and frequency. Risk factors for drug toxicity include severe reduction in GFR, renal clearance of parent or active metabolite, and low therapeutic index of the drug. When total body clearance of a drug is predominantly carried out by renal excretion, i.e. when renal clearance exceeds 0.7 of total clearance, then drug accumulation will occur in renal failure. Examples include aminoglycosides, chloropropamide, digoxin, alkyronium, galamine, tuberculin, and pancuronium. There is therefore a need to reduce maintenance dose or frequency of dosing of these drugs. When renal clearance is less than 0.3 of total clearance, renal disease will have little effect on drug elimination. Safe drugs in CKD includes lormetazepam, midazolam, temazepam, propofol, isoflurane, desflurane, halotane, saxametonium, atracurium, cisatracurium, alfentanil and remifentanil, bupivacaine, lidocaine, and paracetamol. Drugs safe in limited doses or reduced doses include ketamine, etomidate, thiopental, sevoflurane, vecuronium, rocuronium, fentanyl, morphine, and oxycodone. Contraindicated drugs in CKD includes enflurane, pancuronium, petidine, codeine, tramadol, and NSAIDs. Pharmacodynamics. Hyperkalemia may contraindicate saxametonium use. Avoid nephrotoxins, especially in the perioperative period, when the patient may be exposed to other factors such as hypotension and dehydration that causes renal damage. Examples of nephrotoxic drugs include ACE inhibitors, angiotensin II receptor antagonists, gentamicin, NSAIDs, and contrast media. The patient is likely to be on multiple medications, the effects of which must be considered, such as antihypertensives, diuretics, insulin, and other hypoglycemic agents. If the patient has had a previous transplant which is now failing, the patient may be taking steroids and immunosuppressive drugs. These drugs need to remain therapeutic to avoid rejection of the transplant. Seek advice from renal physician regarding dosing perioperatively while nil by mouth. The patient may require steroid supplementation due to previous or current steroid treatment. The patient may be anticoagulated due to recent heparin administration for hemodialysis, or hemodialysis may be planned post-operatively, requiring anticoagulation. This may contraindicate regional techniques such as epidural analgesia. The risk of bleeding and potential need for blood products may also occur. C. What problems may occur with post-op pain management in this patient? Kindly refer to the video Finals SAQ41 Renal Transplantation, CKD and AKI for the answer for this section. Thank you.